Hi, everyone. Welcome to the 103rd session of the MedAI Group Exchange Sessions. This week, we have Zhi Huang from Stanford here with us to speak about their work on foundation models for pathology research. He's a postdoctoral fellow at Stanford University. And in August 2021, he received a Ph.D. degree from Purdue University, majoring in electrical and computer engineering. So his background is in artificial intelligence, digital pathology, and computational biology. So thanks so much, Zhi, for joining us today. And before we start, do you have any preferences on how you'd like to take questions? Is it okay to interrupt you, or would you like them all at the end?
Yeah, feel free to interrupt me anytime. Yeah.
Awesome. Okay, so I guess let's try to make this session as interactive as possible. And without further ado, let me hand it over to you.
Yeah, sure. Thanks for your invitation, and thanks for having me today. I'm Zhi Huang, a postdoc at Stanford, Department of Biomedical Data Science and Department of Pathology. I'm actually at the Pathology building right now. So yeah, it is my honor to be here at MedAI seminar. So I'm very happy to share our recent work in visual language foundation model for pathology research and education, which was recently published in Nature Medicine and being fortunately selected as September cover. Yeah. Okay, so let's get started. Before we dive into the detail, I want to give a little bit more background about the pathology and why it is so important. So it is known that pathology diagnosis is the gold standard that informs all the subsequent medical decisions, such as a treatment plan and the surgery, like follow-up strategy for the hospital in hospital care, right? And the pathology is the ground truth. And here is a workflow, a typical flow that how a patient might be visit the pathology department to get a diagnosis from the clinical sign to radiology inspection and all the way to pathology and to get a treatment. So imagine a patient showing some symptom. He or she might get a routine health check. For example, blood test. There are more than 7 billion clinical lab tests performed in the US like this, right? So it's pretty common. But not all the blood tests showing some symptoms. So if there's no obvious abnormalities, he might just came out of the hospital, he or she. Yeah. But if the blood test suggests some abnormality, or if the routine health check, or if that patient feels terrible, the radiology report might suggesting something wrong in their body, right? Some pattern in the body. And if the radiologist suspect it's a cancer, the patient might be going to a additional surgery. And if the surgery found no lesion, or if the surgery finding is benign tissue, then it is all well. But if it has the lesion or malignant tissue, that means it could be cancer, right? It could be a bad signal. So this pathology examination, by taking a piece of the patient tissue to make a diagnosis under the microscope, is really crucial for deciding what treatments comes next. And it might be just polyps or adenoma, but if it is cancer tissue, then the pathologist will determine what is the tumor stage, what is the tumor grade, and what is the potential subtype, what is the differential diagnosis. Is there any potential mutation? Is there any other potential like cellular, subcellular pattern that could be rarely found in that patient or in that type of cancer, right? For example, one of the examples I always like to raise is endometrial biopsy. In endometrial tissue, if a patient was observed a pattern of presenting plasma cell among the millions of cells, if there any just 1 or 3 plasma cells exist, that is the signal of the failure of pregnancy or the infertility, right? So finding that is really crucial, and only pathology diagnosis can tell the existence of plasma cell. And after that, once we get a differential diagnosis from the pathologist, it can influence the treatment strategy and ultimately impact the survival rate. Another example I would always like to mention is colon cancer. In colon cancer, when we take a surgical resection of a colon tissue, by removing the tumor, we not only remove the tumor, the pathology department also remove the adjacent lymph nodes. Usually it's up to a dozen of lymph nodes, and they will have a careful inspection of those lymph nodes, adjacent lymph node, to see if there are any potential tumor metastasis, meaning the tumor cells will go from the primary tumor site in the column to the adjacent lymph node. And if the patient was observed more than maybe 3 lymph node metastases, then the treatment strategy should be more like we should use a higher dose for chemotherapy, for example. So that is a really crucial, and only pathology diagnosis can tell. Yeah, so that is the how we say, why we say pathology is medicine's ground truth. And so why we want to analyze the pathology images. Similarly, as what we just mentioned, on the diagnosis perspective, it is medicine's ground truth, right? But on the precision oncology side, just because it is a ground truth, and the tumor microenvironment and its spatial relationship of cells can tell us maybe the understanding of can help us understand the cancer heterogeneity or stratifying different patient subgroups, right? Or if we can use the image phenotype features to forecast the survival and treatment outcome. Let's say before the treatment, based on the image feature, can we predict the treatment success rate, right? This is really useful to choose the best first-line treatment option, right? And follow up to that is treatment recommendation. And when we talk about pathology image, we talk about in this type of study, we work on the digital pathology, meaning usually those whole slide image can be really large, can up to 3 gigabytes image, right? And with dimension typically up to 100,000 by 60,000 pixels inside, right? So it's really a large image. And one typical approach is to tile into multiple patches, and for each single patch, we have a embedding summary of that single patch and aggregate all those predictions together to give a whole slide patient level suggestion. Well, but that kind of beyond our analysis or research scope in today's discussion, but it is worth to mention, yeah, it is whole slide image, it's really large. But in today's talk, we'll be focusing on the patch level analysis. Yep. So we talked about the pipeline of tissue section, all the way from tissue section on the microscopic slide and digitalize it and tile into multiple patches. The downstream task can be for the computational side. In the computational side can be tissue type segmentation, right? Segmenting out like the region of tumor, the region of, let's say, germinal center, for example, the region of malignant tissue, and so forth. And we can also, a lot of computational analysis was conducted on the cell level, such as cell level, cell segmentation and classification. And those are more like on the diagnosis or the computational side. Linked to the precision oncology, people usually maybe correlate the image feature to genetic information such as the mutation, or use those image feature and additional genetic information to forecast the treatment outcome or grading, staging, or predicting the survival rates. So really it's like 2 different research tracks, either clinical diagnosis or precision medicine. Well, not only 2, but those 2 are 2 primary research interests in this digital pathology area. Yeah, so for today's talk, we will be focusing more on the clinical side, especially in the image analysis and education. Yeah, so that's the background of digital pathology and how pathology is important to us. So if we don't have any question, and let's go to the next. So, okay, although pathology is medicine ground truth, pathology is important, but it is human to make the final diagnosis right now, right? Under the current regulation. So clinicians needs to make diagnosis, and clinician needs to make consensus for diagnosis. And here is an example suggesting different clinicians may come up different strategy in the diagnosis in pathology department, and different clinicians may have, based on different educational background and practice in different region, they might have a different strategy on how to look into the slides. So here's an example on a Twitter. A clinician was curious about whether other colleagues test Ki-67 antibody in breast carcinoma, right? So she was actually surprised that the CAP, the College of American Pathologists, does not really recommend perform it routinely, right? So following up to that point, a clinician from Germany said that they always perform it and report it. And a clinician from Australia said it is around 15% of the time to perform Ki-67 tests. And the clinician from Spain said he always do it, but he believed there's a large amount of pathologists may not perform it, right? Very interesting discussion on the Twitter. So we have to accept the fact, pathologist or clinician, they are expert medical worker, they are professional, but we have to admit the fact that there's a large discordance on some of the pathology practices, right? So that's the background, that's the fact. And another very interesting background, actually, it's a poll on the Twitter. So do clinicians make diagnosis based on the subjective gut feeling? A recent interesting survey by this cool pathologist suggesting that over 57% of the clinicians make the diagnosis includes the use of subjective gut feeling, right? So it doesn't really imply that pathologists make the arbitrary diagnosis, but it's really underscored the necessity for a tool or algorithms to mitigate such disparities or like intra-observer variability, right? So it's so one way we could think about this computational approach, right? And that's how we might want to bring AI and machine learning, or even just calculation, just normal computational analysis into this playground. And so when we think about this, when we think about AI could be able to assist clinicians in making those type of analysis and diagnosis, on what aspect we could be able to help them, and meaning that's what can be a useful tool to assist the clinician, right? For example, maybe a pathology search engine, right? Just like Google, allows clinicians to match their cases on their hand, the glass slide case, to the one they have gone over before, or like the one on the textbook, right? Because pathologists typically compare their cases during their work to the classic examples. And so this is how they learn and become better at their job. And the more cases they see, the more they learn. So that's how a clinician from resident pathologist to a fellow to a attending pathologist, this is how they get learned. And so could we use a similar method to help pathologists to learn, or simply assist them in retrieving the similar cases, maybe perhaps enhance their diagnosis, right? So this is really a task that we want to, this is really a question we want to answer. Yeah. And so the answer could be yes. And now let's officially dive into the topic that we're gonna share today. So when we talk about AI, machine learning, we talk about algorithmic and data-driven statistical inference, right? And what is the most important thing? One of the most important thing in machine learning? The machine learning needs data, right? But we know that machine learning needs data, but computational pathology faces the following barriers. First of all, there are more than 8,000 disease types and even more learning tasks, right? But compared to other machine learning data sets, which typically has millions, right? Or even billions of data, such as Lion, which has over 5 billion of image and text pairs, or the ImageNet, which has 14 million images with careful labels. There are really few annotated pathology image data sets, especially with natural language description. So this is really impede the advancement of AI in pathology. Or at the same time, there are tremendous amount of high quality de-identified medical knowledge shared by thousands of clinicians on the public forums, such as medical Twitter, Lion, or Wikipedia, right? Or even LinkedIn. So these data establish a really valuable asset for us to maybe train a general purpose medical AI that can that can assist us in learning, navigating, and analyzing digital slides. So in this work, we create OpenPath dataset from Twitter and other public sources such as Lion, based on the US CAP 32 pathology hashtag guidelines. So those images and text are from 32 different hashtags or 32 different subspecialties. And we then follow a stringent cohort inclusion and exclusion criteria, including the removal of non-English tweets, retweets, and sensitive tweets. In addition, since we believe the most liked comments also convey more or less relevant medical knowledge, so we also include those top likes replies within the post, right? And so these data were further cleaned by including the removal of sentences with question marks, because it usually may contain less medical knowledge when the people start asking the question. And in addition, we also perform the text cleaning, including the removal of emoji, hyperlinks, and so forth, or like repeated space or repeated question marks or repeated like other symbols. So at the end of the day, here is one of the example text after the cleaning. Small infiltrative looking glands with crystalloid secretion are suspicious for prostatic adenocarcinoma, right? So this is the one typical caption aligned with the Twitter post. So now we can see the advantage of annotating pathology image by using natural language. Why? Because it just contains several even more key concepts of the image, including like small infiltrative looking glands. That's the knowledge it conveys, right? And crystalloid secretion. This is additional information that's shared, comes from the text description. And the tissue from prostate and a potential malignant tissue, adenocarcinoma, right? So we really get a lot of more knowledge compared to categorical labels such as 0 or 1. Yeah, so after that, we get a bunch of pathology hashtag image and text pairs. So, but some of the images may contain maybe just PowerPoint slides with a pathology hashtag, or maybe some pathologists, they attend a conference, so they also have a hashtag, but put a selfie in the Twitter post, right, with a pathology hashtag. So we have to remove those irrelevant text, irrelevant data, and the data quality is really important to train the machine learning model, right? We all know that. Yeah. So we further trained a pathology image classifier to remove those non-pathology images, right? And at the end of the day, we curated the data with 16 years of knowledge with a total of 208,000 high quality image text pairs. By the time we published this work, it was the largest public pathology visual language data set. Yeah, so feel free to ask me any questions, but I'm gonna dive into the machine learning side.
I had a quick question actually.
Yep.
So in your previous slide, if you go back to how you actually collected this data, when you decided the inclusion, exclusion, or basically data cleaning and data selection, did you use any ML for that part, or did you did you have like simple rule-based selections, or did you try to use like more fancy techniques as well? And what were your thoughts on how to do that?
It's good. It's a good question. Yeah. So all those details of data cleaning are in the method part, but for this part, it's relatively simple. For text in English, actually in the Twitter post, we scrape on from the Twitter. It can automatically tell us if it's an English written or not, right? And we can also easily to tell if it's a retweet or not. Twitter also tagged us if it's a sensitive tweet or not. But for reply with most like, it becomes a little bit tricky. Sometimes the most like reply could be maybe just thank you, or like such a beautiful image like that, which doesn't really contain any medical knowledge, right? So we only include those replies that contains at least one medical, at least one word that is related to the medical field, such as like adenocarcinoma. Yeah. And for the text cleaning, well, there's no magic, just remove different type of emojis, right? For the pathology image classifier, we actually train an image classifier The negative sample is coming from the CFAR10. The positive sample are from the image patch. We get it from a whole cell image, a bunch of whole cell images. So that's how we did the pre-process.
I have a question here too. So like, what's the percentage of the image that are removed?
Yeah, it's a great question. So, yeah, so I think in our paper, we scraped a total of 243,000 images. And after the removal, we get 208. So it's about, yeah, like 20%.
Okay.
Yep.
Thank you.
And a question from the meeting chat from Ramon asked, have you tried to categorize images by their zoom level or size? As I assume these sample slides will have a lot of different variability. This is really a great question. So different from radiology images, pathology images is a gigapixel image, right? As we mentioned, and the magnification is really, really important. If you train a machine learning classifier on the 20x magnification, you will see a really bad performance when you apply to 40x because all the cell size will become double in your like out of your training distribution. It's a really important task. So here we are not gonna do such type of magnification analysis or like cleaning, just because our purpose is want to create a foundation model to contain as much of the pathology medical knowledge as possible. So we will automatically will assume that whatever comes with whatever magnification that comes from the image, you must the Twitter post must associate with a very detailed, well annotated text description related to that image. So we basically contain so we in short, we basically do not really care about the magnification. Yeah, it's a great question. Okay, so let's move to the next about training the OpenPath data. So we use OpenPath data to train our general purpose pathology AI. For text in the Twitter post, we fed into a very standard OpenAI Clip model, the text transformer, right? And convert each text into a vector right here. For the image in the Twitter post, we fed into a vision transformer and convert it into a vector with same dimensional space. So like it might be really trivial for computer scientists or like computer science students, but it could be difficult to understand by medical students. I apologize for that, but let me explain it a bit more. So the original input for text encoder is a natural language sentences. It could be having various, a varying length of the data, right? It could be just 3 words. It could be more than 10 words. It could be 100 words. So different lengths of text. After the text encoder, we will convert it into same dimensional space, meaning it will always become a vector with dimension 512. For all images, it is doing the same thing. Whatever the image comes into the image encoder, we will always convert it into a vector with the same dimensional space, 512. And just because we will convert both into same dimensional space, we can compare their similarity, right? By doing some cosine similarity calculation, right? So that's how the Clip model work. So we basically just train the model with the entire OpenPath data. When we say we train, we actually do the transfer learning. So by compare, yeah, let me go back to here. So by trying to encourage a higher cosine similarity between the paired image and text, and try not to impose a try to impose a lower similarity between uncorrelated image and text to make the source cosine similarity matrix be more close to a diagonal matrix like that. So this is a typical contrastive learning loss function, how it works. Yeah, it's not novel, it's a widely adopted technique. So we finally train a Clip model using contrastive loss and comes up with our Plip model, which stands for Pathology Language Image Pre-training Model. So that's how we get the Plip model. And so Plip model is a foundation model that can perform many downstream tasks. So for example, Plip can classify new images without further training. So that is called zero-shot classification. So let's first dive into the zero-shot classification. What is zero-shot learning? Here's the definition. When we train our Plip on the OpenPath data, we can directly apply the model to any target tasks. And the target task can be maybe tissue level classification, for example, distinguishing tumors, adipose tissue, lymphocytes, stroma, and so forth. Or the target task can be just simple binary classification, such as distinguishing benign and malignant. Or the target task can be cell type classification, such as distinguishing neuron, astrocytes, oligodendrocytes, and so forth. So essentially, zero-shot can help classify image with any given set of candidate label without further training. So that is the definition of the zero-shot learning. And so now let's see the flow chart. Suppose we have an input image. After the image encoder, we get an image vector. And at the same time, we can input a list of candidate sentences. It can be 10 candidates, or it can be 20 candidates. It can be as much as you can. So after the text encoder, we will compare the cosine similarity of the image vector to all the potential text vectors. And the final prediction is the candidate text with highest cosine similarity. In this case, is H&E image of tumor. So zero-shot is powerful, right? Because it can apply to any new task immediately, and it is especially useful for rare or novel disease identification. We evaluate the zero-shot ability across 4 external independent data sets, including catheter-column data sets with 9 different label candidates. And we found Plip achieved the weighted F1 score of 0.6 to 0.8 compared to only 0.1 to 0.5 for the previous Plip model, suggesting up to 28 times improvements. And so the confusion matrix, by further diving into the catheter-column data set, the confusion matrix in the catheter-column data set also suggests that Plip model can accurately distinguishing several important tissue types such as adipose tissue, right, or the fat, or the colorectal adenocarcinoma epithelium, lymphocytes, and smooth muscle. And the UMAP, if we further look into the UMAP plot of the image vectors, it suggests that Plip is doing pretty well in distinguishing different tissue types, right? So zero-shot is useful if we want to simply plug and play the model in a new environment. But if we want to pursue a higher accuracy in our research, for example, classifying tissue types, Plip is also the ideal model for transfer learning. So here is the definition of transfer learning. So after we train the Plip model on the OpenPath dataset, in order to achieve a higher classification performance on the target task, we may further train it with additional data that is coming from the target dataset to achieve a higher performance, right? And so there are 2 types of transfer learning. The first type is linear probing. Essentially, we add a linear classifier on top of the image encoder. And with the image encoder entirely remained frozen or untrained. And we just only train the last hidden layer on the linear classifier. It is very useful because you can easily fine-tune and fit into a target data set within only a minute, right? Because you don't have to train the entire backbone, just need to train a top classifier. So we evaluate the Plip across 4 external validation data sets, all suggesting Plip is the state-of-the-art approach in achieving, say, weighted F1 score is on average 0.89, while the second best model was only 0.86, 87, right? In order to further improve the inference performance, we can definitely perform the entire fine-tuning by training both linear classifier and entire image encoder. So this may take a longer time to train, right? But it can ensure the highest performance. So let's first dive into the result in the lung cancer data set. Okay, so we found the x-axis is total amount of data, training data we used, and the y-axis is weighted F1 score. The higher, the better. So we found Plip, color in blue, can consistently outperform the vision transformer base, colored in orange. With those two has the same model architecture, but Plip was pre-trained on OpenPath, and this vision transformer base was pre-trained on ImageNet. And so we can see the improvement by looking at the higher weighted F1 score, given the same amount of data we train, right? And the improvement is especially large when we only use 1% of the data, training data. The Plip can easily achieve 0.82, but the same model architecture vision transformer base can only achieve 0.64. What does that mean to us? Meaning if you only have 70 images in your pocket, you don't have large data set, you can easily train. If you still want to get a higher performance, it's better to start training with Plip rather than a different model architecture. So that's the basic concept. And so this finding is consistent across all 4 external validation data sets, right? So in another words speaking, in the future, take an example of myself. If I want to train a classifier for pathology image, either focusing on tissue level classification or for focusing on the cell level classification, I would prefer use Plip as the backbone to further train on it, because it will give us a higher performance, because it already know a little bit more about the pathology knowledge since it was trained on OpenPath. So that's the basic concept. Yep.
Quick question here,
Yep.
kind of based on Ramon's comment from earlier. So during inference, is there any restriction on what resolutions you can pass, or while transfer learning, for instance, like one data set might have really high magnification and the other could be lower magnification? How do you deal with those things?
Yeah, this is a great question. So in the transfer learning, because in the transfer learning, we have to have some additional data from the target task to train the original model, right? So we would suggest training the model with the same data in the external data set. Meaning if you're working on 40x image, you better train with 40x image, right? Like that, yeah. It does become challenge in terms of model forgetting if you train extensively on, let's say 20x in breast tissue, but apply to maybe colon tissue at 40x. That part could be interesting to further evaluate on. But yeah, I haven't done that yet, but I think that could be very interesting, meaning that, well, to achieve a higher performance, it's better to train a model with the same data, or just maybe similar distribution, right? Data distribution.
That makes sense. Thank you.
Yep. Okay, so we have demonstrated the usefulness of Plip in academic research, right, by introducing the zero-shot classification and transfer learning performances. And now let's see the utility of Plip model for education and second opinion with image retrieval, including the text-to-image retrieval and image-to-image retrieval. So let's first dive into the text-to-image retrieval. Similar to the Google search, right? We can input any text. So the text encoder will convert it into a vector and will compare and match the most similar image in the candidate pool scored by the cosine similarity. So this is extremely useful when we want to retrieve an interesting case in a database. And different from Google, we can directly match the text to image by cosine similarity, allowing the best searching experience. So if time is permitted after the presentation, I can do a live demo about this text retrieval, right? So, but we evaluate the text-to-image retrieval task on Twitter validation dataset first, which the validation dataset is dated after November 15, 2022. In addition, we also evaluate in 3 independent datasets, including the Pathpedia website, PubMed collection, and Pathology book collection, right? So we use recall at top K to measure the effectiveness of retrieval system. It is basically calculate the proportion of target images that were successfully retrieved within the top K images. And the score ranges from 0 to 1, the higher the better. But this task can be really challenging. We wouldn't expect to see a very high recall at top K. And just because pathology image, especially in our data set, one sentence could potentially map to many images, and many images can look pretty much the same, right? And so, but nevertheless, we still observe a huge improvement compared to the baseline Plip model across 4 external validation datasets, with an average improvement of about 4-folds. And compared to the random retrieval, well, basically just random, it's improved up to 15-folds. Average improvement is 15-folds. So here's an example. If the input is breast tumor surrounded by fat, the system will comprehend your sentence and return you the closest match. In this example, in the middle little like region of interest is tumor, right? And around that is some muscle and connective tissue, and those looks like a net with white color is actually the fat. After staining and washing, those adipose tissue cells will disappear after the washing, so it will become vacant at here. That's the adipose tissue or fat. So now you can use the Plip to search image in our website, in our web demo. And lastly is image-to-image retrieval. This is the most exciting, I think this is, I would personally think this is the most exciting result and most meaningful or most useful tool in the real clinical setting. Similar to the text-to-image retrieval, the input for that image-to-image retrieval now becomes image, right? Suppose you're looking at a whole slide image in your hospital, in the hospital side. You open a digital pathology viewer, maybe take a screenshot and upload to the system, and the system may be able to retrieve the closest image match, right? So this is extremely useful because if the user wish to search similar images for educational purpose, if you are teaching a class, or maybe just seek for a second opinion, right? This just allows user to compare their cases with other classic examples, just like this this example I shared before, right? This is how pathology get learned, right? Pathologists get learned, and having a better retrieval system, meaning if our retrieval system can work better than maybe Google, then it will really benefit the educational purpose, right? So that's the basic takeaway message. Okay, so we evaluate the Plip retrieval task, image-to-image retrieval task under 3 unique data sets, each with a specific focus, including the 9 tissue types, 19 organ types, and 24 staining styles. So among all the evaluation, our Plip model achieves the state-of-the-art retrieval performances, right? So if you see a higher line, and here is an example of image-to-image retrieval. We input the image featured with a lot of mitotic figure. Those little dot color in with dark little dot is actually mitosis or mitotic figure. Why mitotic figure is important? Because more mitotic figure you observe within a tumoral region may suggest the tumor is growing rapidly, right? Growing crazily. And the aggressiveness of growing in tumor is linked to the tumor grade, and different tumor grade will lead to different treatment options. So finding the mitosis is really important, counting the mitosis in some of the clinical department. Okay, but I'm a little bit off of the topic, but here is the top result of the Plip image-to-image retrieval. So we found that Plip is able to capture the key concept of your input image, which is featured with mitotic figure. And the most relevant image that Plip retrieved is also featured with 2 different stages of mitotic figure. This is really exciting, right? This is one of the best examples I will always like to share. Right? So now the search engine is also available online at Hugging Face. Any questions so far? Well, let me just dive into the next stage. In summary, we demonstrated that.
I want to ask, how do you quantify that whether the 2 images are similar?
I see. Yeah. So the question about how how do we retrieve the image and how do we rank those images, right?
Yeah, but no, I mean, basically some metrics definitely you can match, but in the clinical domain that you give you an image that you want to see the similar image, how do you quantify that it's similar in kind of disease or appearance or severe of the disease outcome, even outcome?
I see. Yeah, it's a great question about how do we quantitatively evaluate the performance of image-to-image retrieval, right?
Yes.
On both the research side and clinical side. To evaluate the performance of retrieval, we compare those three data sets. But this might not be the real clinical situation, right? So this can be by the time we evaluate the image-to-image retrieval, we were focusing on tissue type, the ability of distinguishing different tissue type, organ type, and staining styles. But in the real clinical setting, it is really a good question. Sometimes maybe pathologists are looking for different features or different type of things they want to retrieve, right? It's a, yeah, so it could be happen. And that's how in our retrieval system, we not only retrieve the top one most relevant image, we actually give you a rank and the top 5 most similar image for you to make the final call. So yeah, meaning the retrieval is not perfect. The clinician may need to make the final judgment based on that. Am I answering your question?
Yes. So then I just want to ask, so basically you kind of retrieve those feature of your image domain that are 512 features that is similar to the input image, right?
Exactly. Exactly.
Thank you.
Yep.
And question about the follow-up question. So what I understood was the definition of the similarity from the image-to-image retrieval is can you go back to the previous slide, by any chance?
Sorry, can you repeat your last sentence?
Can you go back to the previous slide, please? Yeah, so what I understood is the definition of the similarity is decided by the tissue types, organ types, and staining styles. And so you thought those 3 things are the most important criteria to define the similarity.
I see.
And is that right?
Yeah. Yeah, this is a nice question. So the question is about how do what's the rationale of choosing those 3 different evaluation data set and why are those important, right? Yeah. So, am I right?
Oh yeah, right. Yeah.
Yep. So yeah. So I would personally think the organ type is one of the most important retrieval tasks for me, because I want to see to what extent can the machine learning model tell us if a region of interest of tissue is actually coming from either liver, lung, or breast. This is important for me to in my research side. But I think on the clinical side, tissue type diagnosis is even more important for a lot of clinicians, because one of the most painful clinical diagnosis is differential diagnosis, meaning, okay, we know this is a breast adenocarcinoma, but can we further make a additional differential diagnosis upon the fact that it is already a tumorous tissue? And that is really painful. And a lot of clinicians has to consult their colleagues or maybe searching for online resources to assist them making the final call. And imagine we will have a perfect image-to-image retrieval system, then we will be able to accurately tell us what is the closest tissue type that we are looking at. And associated to that image is a differential diagnosis. It basically can letting us know the nearest, the closest as possible case in the history to assist our diagnosis. So yeah, all those different tasks can be very important and useful. And that's the rationale we select those different tasks to evaluate on.
Okay, yeah, thank you.
Yeah, no problem. Okay, so maybe let's start, we still have 10 minutes. So yeah, so let's make a conclusion. Yeah, in summary, we we demonstrated that the public data annotated by natural language is a tremendous resource to advance the pathology AI, even from the public forums, even from the internet, right? And the foundation model Plip, it can perform various of downstream tasks that can accelerate the research in pathology and education in the clinical side, such as the zero-shot and transfer learning and image retrieval for education and second opinion. Since release, the Plip model has more than 100,000 downloads at Hugging Face. Yeah, so we're really excited to see how it may contribute to our society and this computational pathology field. And now you can start using Plip for research. Here's a Google Colab tutorial. We also have a GitHub repo having a lot of different tutorials. But basically, you can easily download and install Plip model and try it with your own data and see how it performs. And I would honestly suggest whatever tissue type or cell type analysis classification task, try to use Plip pre-trained model rather than use an ImageNet pre-trained model, because Plip is really doing better than ImageNet. Yeah, pre-trained. Yeah. Okay, so so that's so that's about the pitching. So what's next? We have presented the Plip model trained on the OpenPath. It was the largest visual language pathology data set. But this field is moving too fast, and it's not going to be the largest anymore. But so now we're curating an even larger data set, OpenPath v2, with over 10 million of data containing H&E image, IHC image, and other type of pathology images, with always detailed natural language descriptions. So the ultimate goal is we want to accelerate this digital pathology field and help us to achieve better and faster diagnosis, make the life easier and more fair to both clinicians and patients. Along with the dataset curation, we are working on Plip. It's a large language model based search engine and chatbot for education and second opinion with the medical image understanding. And here is a real screenshot of the Plip platform. So the platform can answer basic pathological questions, similar to the GPT-4 vision, but something we do beyond the GPT-4 vision, such as we can help you count the total number of cells within the image. So if you ask how many cells in this image, we can directly tell you there are around 234, exactly 234 cells in this pathology image. And when the user first asks, what is the likely diagnosis if it's from breast tissue? It also gives you the correct answer, which is PASH. And it also gives you several suggested questions for you maybe to play around with a chatbot or learn some additional medical knowledge. Yeah. And
can I ask a question about the
Yep.
chatbot?
Mhm.
So here, is it only for the pathology or it's for general clinical questions?
It's a good question about so the question about to what extent our chatbot can help answer the clinician's question. So
Right.
at least our minimum viable product MVP is to help clinicians doing better in their pathology job. Well, I have to admit that a lot of pathology diagnosis, not only by looking to the image, the pattern on the image, it's actually when clinicians make their diagnosis, it's not only looking to the image, but also recalling their medical knowledge, what they have learned during the medical school, in the medical school. So it's like whole set of medical knowledge in the background. So whenever we make a diagnosis, we always need to take the entire medical knowledge into account. Yes, so that's true. So
I see.
yes, so we if you ask some medical knowledge, well, a little bit more detail about this architecture, model architecture, the infrastructure is, if we observe the user is asking some question that maybe a general purpose large language model can answer, we will be able to call the GPT-4 to do that expert language answering. For image related question, we will call our Plip engine with Plip model and additional model to make the diagnosis or counting the cell and so forth.
Is the counting the cell accurate? Can you show the segmentation result?
It is accurate. I bet there must be over 200 cells. Yes, we use a very special way to count the number of cells. Yeah, there's a very sophisticated pipeline to do that. Yeah, it is accurate. Yes, good question.
Thank you. Thank you.
Yep. Well, another little bit more information is if your input image is the magnification is too low. If we cannot tell the cells, like if it's like just an overview of the whole slide image, then we just don't count the cells. Yeah. And so there are some other great vision language medical AI, such as Biomed Clip, use PubMed images with a lot of radiology images. And Quilm is a really interesting work based on OpenPath with additional data curated from the YouTube videos. This is really, really cool work. Well, the Quilm is from University of Washington. It's not from Stanford. Yep. I think the title were misorganized. Apologize for that. And so we are really excited to see we are pushing this area forward. And so there are some other limitations for the medical AI. First is, I think we're still lack of a highly reliable visual foundation model for all different type of medical imaging analysis. Even like GPT-4 vision cannot do everything, right? So yeah, so we are still working on that. Everyone is still working on that. And the second issue is about hallucination. And I think there's a question from the meeting chat by Thomas. What large language model are you experimenting, and how is the hallucination problem? Yeah, so this is exactly the current limitation. We cannot guarantee to whether the model will hallucinate, and we cannot. It is also very challenging for us to avoid answering hallucinated answer, right? So in psychological aspect, it is better to not answer question by answering rather than answering wrong, rather than returning wrong answers, right? So if you have a apparently wrong result, it will greatly reduce the trust between human and AI. So that's another issue. And the third issue is medical images are really fundamentally different from general visual images. We have discussed about the data set, the total number of data in ImageNet in Lion. They have billions and millions of data, but pathology images, we really, or I mean, in general, medical images needs expert annotation. And we are really, in the limit of data and especially the knowledge. Annotating medical image is more expensive than annotating cars, bicycles, and sky, and so forth, right? And one of the great example, I think it comes from Hinton or someone else. He suggests that a good analogy, an adult can learn how to drive a vehicle in 17 hours, right? But machine learning may need to train a lot. And we're not quite solving the autonomous driving yet. I recently experienced the Tesla autonomous driving. Well, it's not still that intelligent. So we're not solving the autonomous driving. So medical AI is even way to go. Think about it. An adult can easily learn how to drive a car in 17 hours, but a medical student needs to learn 8 years to become a clinician. So that's the whole different level of difficulty in medical imaging and medical AI. So yeah, so we are still facing the limitation, and we're still working on that. Hopefully the future is brighter and more promising. And is there any other question? Oh, okay, cool. Yeah, no more question. So yeah, after that's all. So I would like to thank my collaborators and advisors. Federico is the co-first author of this Nature Medicine paper. He's truly a genius computer scientist. Mert is a fantastic and talented researcher. I would also like to thank our amazing advisors. Tom is the chair of pathology department, and James is our PI leading the research. And without their excellent guidance, we couldn't achieve this progress. So thank you, and thank you all.
Thank you so much. This was a wonderful talk, and Yeah, especially like the little thank you generated by DALL-E in the image. So yeah, I guess before we get started on questions from the audience, maybe we can give a round of virtual applause to our speaker for this wonderful talk. So yeah, and feel free to ask your questions.
Yeah.
I can start with one question. Thank you for this amazing presentation. This was not really particular to your model, but I was just thinking like the way we have been using foundation models, do you think there is gonna be a bias based on data representation? Because now we're learning about, racial bias in AI diagnostic radiology tools because, okay, they didn't see while training a lot of African-American patients, and now they perform poorly for African-American patients. So when we're training on like such large data sets and they have this amazing emergent behavior and they can pretty much do kind of a lot of things. But do you think like fundamentally we're still gonna run into that roadblock? Because no matter how much data you have, you still have unbalanced representation.
Yes, it's a great question. So the question about the limitation about foundation model, especially on the biases, for example, the minority group or like a subset of pathology subspecialty, which are lack of the number of data sets. Yeah, it is true. I think such type of biases issue is especially raise considerably attention in dermatology classifier, because when people train a dermatology classifier, they look at the skin color, right, and to see if it's a melanoma or not. But well, really, it's really a bias including different group of people, population. Yes, so that's true. For pathology, I think it's less crucial on the population side, but it's more on the subspecialty side. When I say subspecialty, I mean, think about it. Let me go back to the previous slide. When we established this OpenPath data set with 32 different hashtags, here, 32 different hashtags, it doesn't mean all single hashtag will have equally number of data, right? We do observe there are a lot more data on breast path and maybe GI path, but some of the subspecialty, such as BST path, we're really having limited knowledge share on the Twitter. And when we try our image retrieval on those different specialty, we also realize it may be not doing that well on those subspecialty with fewer data. Yeah, so that is an issue. Yes, and it is very important to collect all those kind of tissue, all those kind of data sets in order to provide all potential type of analysis or prediction. Yeah, it's a great question.
I have a question about the data collection. So you currently collect data from the Twitter, so why not collect data from the Department of Pathology? I guess there's also tons of data there. So what's the, I know it's a challenge, so what's the trade-off and rationale?
Yeah, it's a great question. So great question about, yeah. So when we started this project, we were thinking about the knowledge is really useful from the Twitter because each image patch is associated with a detailed described text. But in the medical school or in the hospital, typically what we only have about the text is just a pathology report, right? And honestly, if you look into the pathology report in the clinical department, it looks like it says a lot, but really it says nothing. It's always describe this slide and this slide. Slides C1, C2, C3 describe a massive tumor, and that's it. Just one sentence describing the whole slide image, which is really not specific to a region of interest. So to get a region of interest level analysis, region of interest level annotation, we have to, it's better to use those Twitter or other internet sources, right?
Thank you.
Yeah, but we are trying very hard to expand our data set to OpenPath v2. We're trying to incorporate all those potential data, yeah, together.
I have a follow-up question about Twitter. So
Mhm.
actually, I'm not using Twitter, so I'm not familiar with the Twitter. So I was wondering if that's common that like histopathology, that medical data is uploaded in the Twitter. So is that only does that only happen in the histopathology data or other medical data like radiology data also uploaded in the Twitter like that?
Yeah, it's a great question about how diverse does the Twitter community share by the clinicians. Great question. So we did look into different type of image modality, including the CT scan or in general radiology or MRI images. But then we realized pathologists are especially interested in posting images on the Twitter. And also it's because it was systematically recommended and managed by US CAP. They suggest several pathology hashtags. So it's really relatively easier for us to search those tweets by the hashtag. And that's how we established the data set. I did try to scrape the radiology images, but I was not able to observe a systematic arranged high quality set. So yeah, that was a little bit pity.
Okay, thank you. And yeah, I had another question about the text to image retrieval. So
Yeah, sorry to interrupt. Just a quick sec. Like I might need to run for a different thing, but I can stop the recording and you can continue the conversation if that's something that people are interested in. So thanks again, Zhi, and yeah, continue. Like feel free to continue the discussion. Looks like a very lively one going on.